today's speaker is Dr. Ravi Shankar. He's assistant professor in Department of Head Neck Surgery, Tata Memorial Center, Varanasi. He will be talking on laser in early laryngeal carcinoma. So, Ravi, I think we can go ahead with the presentation. People will keep on joining.
Sure, ma'am.
Yeah.
Sure, ma'am. First of all, ma'am, I would like to pay my regards and say thank you for giving me this wonderful opportunity. It is always great to present in your alma mater, and I have been your student. It really feels great to be presenting in the same institute where I have been as a student. So I'll be presenting on laser in early laryngeal carcinoma. We all know what is early stage tumor, early stage laryngeal tumor. Basically, the tumors which are localized to to one or two subsites and are not extending to any other part, they are classified as early stage tumor without any nodal metastasis and definitely without any distant metastasis. The goal of our treatment in an early stage laryngeal tumor is basically to preserve these are the patients who have usually relatively good oncological outcome. So our aim and goal of treatment is to preserve the function of the larynx without compromising on oncological outcome, which means that the patient should not require tracheostomy tube or feeding tube, and the functions such as phonation, respiration, deglutition, and airway protection, which means prevention of aspiration, these all functions are preserved. There are multiple modalities of treatment for an early stage laryngeal tumor, which can be open surgical or non-surgical. The surgical options can be open partial laryngectomy or transoral surgery, which can be transoral laser surgery or transoral cold steel surgery. The non-surgical option is radiotherapy. But the Cochrane analysis, which was conducted in 2002, it did not show that there was any advantage of any specific modalities. All the modalities had an equivalent outcome. The major study, the major randomized trial, which was a part of that Cochrane analysis, was this trial which was conducted in Russia. It was published in 1990, and it included around 234 patients from 79 to 87. It showed that for early laryngeal tumors, for both T1 and T2 tumors, the 5-year survival and 5-year disease-free survival was not different between both the surgical or the radiotherapy arm. But the problem with this study was that there was no data on side effects such as or the functional outcome. And when this study was originally conducted, at that time, these kind of tumors, they were largely treated with open surgery or radiotherapy. And at that time, the results of case series, they demonstrated similar survival rates. Since RT offered an option of, it was a relatively non-invasive technique of treatment, and it offered an option of voice preservation over open surgery, and gradually radiotherapy became the treatment of choice. But still, open surgery remained an option of treatment wherever RT was either not available or the expertise was not available to plan the radiotherapy properly over there. Gradually, as transoral laser surgery became a part of the treatment regime, the consideration of voice quality and oncological outcome of transoral laser surgery in comparison with radiotherapy became a matter of debate and a matter of research. This Finnish trial, which was conducted, which was published in 2014, it randomized the patients in two groups, radiotherapy versus transoral laser surgery, and included around 60 patients. The patients were analyzed on the basis of their functional outcome using GRBA scale and stroboscopy and reported self-reported questionnaires. This trial did not show that there was any great deal of difference in the voice quality between the two groups. And this was basically focused on assessment of voice quality, because voice quality was one thing which was of major concern between transoral laser surgery and radiotherapy. But in this study, the patients in RT arm, they reported less hoarseness related inconvenience. The problem with the study was that there was no proper sample size calculation. The statistical analysis was not adequately powered, and the questionnaires, which were the self-reported questionnaires, they were not validated in the study population. Similarly, there was in these meta-analysis, recent meta-analysis, they showed that transoral laser surgery, it had a relative advantage in laryngeal preservation rate. There was no difference in overall survival, there was no difference in overall voice outcome, but there was relative advantage in laryngeal preservation rate, as shown in the meta-analysis by Abdul Rahim. But still, we do not have any concrete evidence to point out in favor or against any particular treatment modality. And this is very well demonstrated by the plethora of systematic reviews and meta-analysis which we have, as can be seen in these tables. But one thing which came out very clearly from the recent meta-analysis, and the recent one, a very highly quoted paper by Vakulik, it showed that the overall laryngeal preservation rate in transoral laryngeal microscopic surgery, laser microscopic surgery, was much better than that in radiotherapy. It showed that control was almost 6 times, there was chances of 6 times better laryngeal preservation rate by transferal laser microscopic surgery. But yet, the last conducted Cochrane analysis also did not show that there was any formal proof that any one treatment is more effective or better than the other treatment. There were several limitations of these studies. All these studies, they had a high level of selection bias, which means that the cases which were either poor prognostic, had anterior commissure involvement, had poor exposure, or in which the assessment was difficult, all these patients were referred for radiotherapy. And very highly selected cases with good exposure, they were selected for surgery. Plus, there was no proper RCT to compare the outcome. There were many RCTs which were started, but they could not be completed, and they were closed due to poor recruitment. As most of the patients who could undergo TLM, they underwent TLM, and who could not undergo TLM, they chose radiotherapy. So to interpret all these studies, the substance of the interpretation is that till date there's no absolute proof, no level 1 evidence that any one treatment modality is more effective than the other. But there is evidence, though not level 1 evidence, that transoral laser microscopic surgery as a primary treatment modality, it is associated with a better and a higher laryngeal preservation rate than radiotherapy in early galactic carcinoma. And we'll discuss about this, that why does this happen. But then if this is the scenario, then what actually helps us in clinical decision making? What helps a surgeon in deciding that the patient should go for what treatment modality? Then cost becomes a major factor. It has been shown that TLM is more effective and less expensive as over radiotherapy when offered as an initial treatment strategy. But still, all of these things, they finally rest on the patient's shoulder and proper counseling. But we have to understand that what advantage does TLM offer? The TLM does offer shorter hospitalization because the patient can be operated and discharged in the same day in a single sitting. It has got lower morbidity over open partial laryngectomies. It has supposedly superior functional outcome over and definitely over partial laryngectomies. It has definitely shorter treatment time as compared to radiotherapy. The radiotherapy takes almost 5 to 6 weeks to complete the treatment, and the patient has to come to hospital every day to get treatment for around 5 to 10 minutes. Patient has to wait. Patient has to spend so much of energy and money on getting the treatment done. Plus, a very great advantage is that when we use transoral laser microscopic surgery as a primary treatment strategy, it leaves open all other treatment options as possible treatment options in cases of recurrence, which means that a patient who has been treated with TLM can again undergo TLM, can undergo radiotherapy, can undergo partial laryngectomy. Hence, this is the primary reason why a patient treated with TLM translates into having a higher organ preservation rate. But yet, before deciding on the treatment modality, we have to take into patient's wishes, patient's concern, and patient's aspirations into concern before embarking on any treatment decision. We have to understand what patient wants. Is patient willing to come every day for radiotherapy, or does the patient want to get treatment done in a single setting because patient does not want to get operated? But we have to counsel the patient properly, both the advantages and disadvantages of TLM. Such as in TLM, we have the opportunity to get the tissue for assessment. In radiotherapy, we do not have that opportunity. But before we go and understand what TLM is, we have to understand what laser is. Laser simply stands for light amplification by stimulated emission of radiation. What does it mean? It means that the light is being emitted by an excited atom or an stimulated atom when it comes into its resting state. And this light emission is amplified by repeated stimulation of the atoms. This is a very basic schematic diagram of laser, the production of or the generation of laser. It consists basically of a lasing medium, which this lasing medium basically determines the wavelength of the system. It is enclosed between two parallel mirrors. We can see these are the two parallel mirrors. This is a partially reflecting mirror. This is a completely reflecting mirror. This medium, it is excited by an electrical source, and these are the two electrodes which excite this lasing medium. So this excitation leads to an excitation of the atoms into from the ground state. And when the total number of atoms which are in the excited state exceeds than the number of atoms in the ground state, it is called as population inversion. Now, when this lasing medium is activated, it begins to release excited photons simultaneously in all directions. A small subset of these photons, they travel along the center line of the laser system in a unified fashion between the mirrors. The mirrors then reflect these photons, and the process of stimulated emission is amplified. And this partially reflecting mirror, this partially transmitting mirror, it allows a powerful and cohesive beam of photons to be released in a straight line as a laser light. So this is the basic concept of the generation of laser light. This is a very brief history of the role of laser in medicine. That ruby was the first substance to be used for laser production, and the role of Jaco and Polanyi in the first for the use of laser and lenses cannot be undermined. But the important thing is we have to understand that there are a plethora of options of lasing mediums, such as ruby, Nd:YAG, argonium YAG, diode, argon, CO2, pump dye. But why do we select CO2 laser? Why do we always use CO2 laser? So the reason for using CO2 laser, one of the most important reason is the laser which is generated, the property of the laser which is generated. The laser which is generated from CO2 as a lasing medium is a laser in the infrared wavelength with a wavelength of 10,600. So this wavelength has a property that it is absorbed by water, and water is practically present in all the tissues, including skin, hair follicles, mucosa, bone. Hence, CO2 laser has the greatest advantage of being absorbed by all the biological tissues. Plus, and because of this property, there was a high level of research which went into the CO2 laser, which led to development of multiple micro manipulators, omni guides, and different manipulation techniques for the CO2 laser, leading to its so much expected and increased role in medicine. Hence, the CO2 laser becomes laser of choice. It has got a superficial effect. It has minimum lateral damage to the surrounding tissues. It can be used as a cutting or ablating laser. If we use proper settings, it can be used as a coagulating laser, but the limitation is that it cannot coagulate a vessel which is larger than 0.5 mm in size. It has its own complications. Plus, with the advantage of Omni Guide now, which is a flexible CO2 laser delivery system, now laser can be delivered up to the tissues directly. But why are we thinking about laser? We have to understand that transoral laser microscopic surgery, it did not originate, it was not the first concept. It actually originated from transoral microscopic cold steel surgeries. Laser surgery, it provided some obvious advantages over cold steel surgery. Since laser is manipulated from a distance, and our hand and instruments usually, one hand is free and it does not obstruct, so it does not obstruct our view. The cold steel cannot provide hemostasis. Laser, if used with proper settings, has the potential to provide hemostasis. We can work at longer distances. For using cold steel, we have to hold the instrument in our hand, and we have to go near to the specimen or near to this site of work. Laser requires minimal tissue manipulation as compared to cold steel. Laser, since the scalpel is not touching the tissue, there is increased sterility, and there are relatively less post-operative complications, which we'll see subsequently. But there was one concern which always bothered people about laser versus cold steel, was about margin interpretability. There was definitely, so the issue was that laser, because of its thermal effect, can lead to charring of the margin edges, and lead to a problem in margin interpretability. The laser definitely has greater degree of artifact, but in the end, there was no difference in overall interpretability between that of treatment by laser margin excision or by cold steel instrument excision. Plus, the voice outcome after laser was relatively better as compared to that in the cold steel, because of the better scarring in laser group. So gradually, treatment by laser took over the treatment by cold steel in microscopic laryngeal surgeries. So it became imperative to understand a laser machine before embarking on the journey of using laser for treatment. So it is important, just there are multiple terminologies which we use during lasing, such as AccuSpot, AccuBlade, scanner, SurgiTouch. What are these things? What is AccuSpot? So AccuSpot is basically the scalpel which is used to cut. This is basic and simple scalpel. AccuBlade is a scanner software modification which helps in generation of lasers of different shapes and sizes, which means we can see over here, this is a curvilinear shape of laser. This curvilinear shape of laser is possible because of this whole AccuBlade and scanner technology. Scanner is basically a device which is connected between the lasing arm and the micromanipulator. We'll see what micromanipulator is. So this is the scanner. This is a scanner which is connected over here. This is a scanner between the lasing arm and the micromanipulator. This is the micromanipulator. It has a joystick. This joystick is basically used to control the direction and the position of the laser. So this scanner device, it is connected between the laser arm and micromanipulator. And with the help of this computer software, which is SurgiTouch software, we can we can control the position of mirrors inside the scanner, and we can generate different shapes and sizes. SurgiTouch, it is basically the software which helps in adjustment of the power and the timing duration as per our requirement. Suppose we want to do laser surgery, and we'll discuss about all these modes as well. We select depth of 1 mm. So in that scenario, the SurgiTouch will automatically give the power and time of duration required. We'll discuss what is time of, what is depth, and what is shape size subsequently. So, and what is micromanipulator? Micromanipulator is a device which is connected to the microscope, and it basically helps in physically interacting from a distance with the laser, and from a distance with using the laser on a sample which is put under the microscope. Suppose we are operating on the larynx, then larynx becomes a sample under the microscope, and we can manipulate the laser from a distance without actually putting our hand between the microscope and the sample, hence providing a better view, better unobstructed view. Plus, since we are operating from a distance, our hand can have little bit, every hand has tremors, has tremors. Hello? So every hand has tremor. So this micro manipulator, it helps in the management and precision of movement. And this cannot be, this precision of movement we can see when we are using it under the microscope. Plus, a very good thing about micro manipulator is that it provides smallest possible beam size of around 250 micron on this focal distance of 400 millimeters, which we use for laser surgery. This we have already discussed. This is the scanner. This is the scanner which is connected over here. This is the end which goes into the lasing device. This is the end which goes into the microscope. And from this end, the software is connected. So to understand the laser settings, there are largely two important things: the spot size and the watt. These two things, they determine the overall power density, which basically translates as watt per centimeter square. So if we increase the spot size and we keep the wattage same, the overall power density which is delivered reduces. So hence, by increasing the spot size, we can give a more of coagulative effect than ablative effect on the tissues. I hope I am clear over here.
Yes, Ravi, you're clear. I think if people will be asking questions, we can discuss later on also.
Sure, sure. So this, and then there's this total duty cycle. This is the total time that the laser energy interacts with target tissue. This is a very important factor. So as we have seen over here, that we can adjust the time off period. So suppose we are giving it, if we are using multiple small pulses in a short duration of time, the total time of period reduces. We'll see over here. So these are the different kinds of waves based on the duty cycle. This is a continuous wave. A continuous wave basically has a overall relatively lower peak pulse and overall relatively lower average pulse energy. So a continuous wave will go something like this. We can see over this here as a red graph. A single pulse, and the pulsed waves can be a single pulse, repeat pulse, super pulse, or ultra pulse. We can see over here, this is a super pulse wave. A super pulse wave has got a very high peak power, but overall the energy which is imparted by the super pulse is less, because the total duration of pulse is very small, and it has got a very sharp peak and a very sharp fall off period. Whereas whereas in ultra pulse mode, this is the gray area, the peak is very sudden. It goes up to the 200 watts. We can see in ultra pulse the peak is 200. In super pulse the peak can go up to 400, 500. But in ultra pulse, this pulse duration is more. Hence, the total peak power is more in ultra pulse. Total average energy imparted is more in ultra pulse. This pulse energy is the factor which determines the tissue impact, and this pulse energy must reach an ablation threshold so that the ablative effect comes into picture. If the pulse does not reach an ablation threshold, there won't be any ablative effect. What will we have then? We will have a coagulative effect. So energy below ablation threshold will cause increased lateral thermal damage, and energy above this threshold will cause more of ablative effect. Hence, ultra pulse has got the most ablative effect, and continuous wave has got the most coagulative effect. We can see these lasing settings over here. So this is basically the screen of the AccuPulse surgery scanner. This we can see the scan button has been pressed over here. So we have scan, no scan, and fiber options. If we select no scan, in that case, we cannot modulate the shape or the depth or the time of. In no scan mode, the shape is fixed, it is just circular. We can adjust the shape size, time off is basically the lasing will be active for the duration. We press the foot pedal, and it will stop the moment we stop our foot pedal. So in a continuous wave, the depth cannot be manipulated by us, because the depth will increase for the total duration we are pressing the foot pedal. So we can see over here, this lasing settings, we have super pulse, repeat mode. We have seen in the previous slide that what is a super pulse mode. A super pulse, it generates a good amount of average pulse energy, and super pulse is also very good for ablation. So in super pulse, if we go into repeat mode, and then we have already decided the total depth that we want to give, then SurgiTouch technology will automatically give us the power which is to be delivered and the time of which will be present between the two pulses. This time off can be manipulated by us. We can change this time off. We can change this power as well as per our convenience. And we can see over there here, because of this scanning technology and this SurgiTouch technology, we can change the shape as well of the scalpel. So if we increase the time of duration, the lateral or the thermal damage to the native tissue reduces. So that is the significance of reducing the time off over here. Sorry, increasing the time off over here. This we cannot get with a continuous wave. We see over here, this is a super pulse continuous wave. We cannot modulate the depth and the time off in this, because the continuous wave will be generated for the whole duration we are pressing the foot pedal. Similarly, this is continuous mode. We cannot commit the depth and the duration, but we can see in single pulse we can control the depth, and this is possible because of the SurgiTouch technology, because as soon as we select the depth, it will automatically give us the power value. But before doing any laser procedure, safety is of utmost importance. All of us are very well aware about the basic safety precautions, but two very important points which I want to emphasize on, that before starting the lasing, we should tell the anesthetist that we are going to start the lasing, so that they get enough time to adjust the level of oxygen concentration to minimum and to stop using nitrous oxide over there as well. This nitrous oxide, reducing the nitrous oxide is basically it is required because the nitrous can go into the basically nitrous has got a higher diffusion coefficient, and it can go into the body cavities, and this can lead, and nitrous is kind of a flammable agent, so it can lead into increased flammability over there. So now coming on to types of cordectomies. There are various, there were initially various kinds of and various nomenclatures for cordectomies. It was eventually standardized by European Laryngeal Society, mostly by Remakel et al. And it was site dependent. Site dependent means that cordectomy types were separate for glottic lesions and supraglottic lesions. For glottic lesions, we can see this is the basic, these are the basic layers of the vocal cord. The glottic cordectomy types were divided as type 1, which was subepithelial, just the epithelium is being removed. Then type 2, subligamental, where the ligament is also removed. Ligament is also removed. Then type 3, transmuscular, we can see the muscles are also being removed over here. We can see this whole depth of muscle is being removed in type 3. Then type 4 is total or complete removal of the cord. Type 5 is extended cordectomy. Extended cordectomy means whenever type A is whenever we are extending to anterior part, anterior commissure. Type B is posterior commissure. Type C is subglottic, which is down or inferiorly, and type D is ventricle. And then there's this was the original classification which was given by Remakel. It was eventually modified, and type 6 was added, which included anterior bilateral cordectomy and commissurectomy. Similarly, there's a separate classification for supraglottic laryngectomy, again given by Remakel et al. In 2019. The type 1 is limited excision. It basically involves excision of very small superficial tumors on the free border of the epiglottis. Free border basically, which means that the part which is above the level of the hyoid. And it is neither involving the arytenoid or any other part. Type 2A is basically the superficial tumors of the laryngeal surface of the epiglottis, which is located above the hyoid, but not exactly on the free border. It can be in the inner surface or the laryngeal aspect of the epiglottis as well. These are the lesions where the resection includes almost half of the suprahyoid epiglottis. Then type B is for tumors which are extending below the hyoid bone. We can see this is the hyoid bone, level of the hyoid bone. This is a tumor which is extending below the hyoid bone, but not going up to the petiole. So in these kind of lesions, a total epiglotectomy is performed, and the section line, it goes through the pre-epiglottic space, and it does not necessarily entail the total excision of the pre-epiglottic space. Then this is type 3A. This is for basically for the tumors extending to the petiole of the epiglottis, and it entails a total and complete excision of the pre-epiglottic space, for the simple reason that this is the channel from where the tumor can spread into the pre-epiglottic space. Now this is type 3B. This is for the tumors which have an infrahyoid extension from the infrahyoid epiglottis onto the ventricular fold also. Then comes type 4A. Type 4 is basically is for the tumors of the three-fold region. What is three-fold region? The region which includes basically the lateral free edge of the epiglottis, the aryepiglottic fold, and the pharyngoepiglottic fold. And it can have extensions to ventricular folds as well. So it basically entails an excision of all these areas. In case the disease is extending to the mobile part of the arytenoid is also included in the resection. It is called as type 4B. But before we take a patient for microscopic laryngeal surgery, a proper diagnostic evaluation and evaluation of the patient is necessary. So careful evaluation, clinical records of the patient, prior treatment, any prior history of radiation, and then proper staging of the tumor, assessment of involvement of the pre and paraglottic space using CT or MRI. Then assessment of the primary tumor volume. Is the disease very bulky? Whether cartilage is involved or not, whether the lesion is extending beyond the larynx, whether there's any neck metastasis, because these are the factors which can affect our overall treatment modality. And a very important thing to assess is exposure. So assessment of exposure was very well defined by Cesar Piazza et al. In 2014. They gave pre-operative clinical predictors of difficult laryngeal exposure. They made a laryngo score. They basically defined 11 factors which can be used pre-operatively to determine whether the microscopic laryngeal surgery is going to be possible or not. So basically they divided the patients into 5 classes according to the anterior commissure visualization. It was class 0, which had complete anterior commissure visualization with large bore laryngoscopes. Class 1, which was having complete exposure with laryngoscope, but with external supracricoid pressure. Class 2, what was the patient was having complete exposure, but it was in a flexion position. Flexion position means that we are having flexion at the neck and flexion at the atlanto-occipital joint. It is opposite of the Boyce-Jackson position. In Boyce-Jackson position, we have flexion at the neck and extension at the atlanto-occipital joint. Then in class 3, the patient is taken in the flexion position and a small bore laryngoscope is used. And class 4, there is impossible anterior commissure visualization. So what they analyzed, and they saw that using the preoperative 11 factors, they could predict, they gave a total score of these factors. So using these 11 preoperative factors, they could predict whether the patient was going to be in a good laryngeal exposure or a difficult laryngeal exposure. A good laryngeal exposure meant class 0, 1, 2, and class 3 and 4 meant difficult laryngeal exposure. So they realized that using all these parameters, if the score was more than 6, there was 94 chances of having good laryngeal exposure. If the score was 6 to 9, there was almost 60% chances of good laryngeal exposure, but yet the exposure could have been compromised in around 40% of the cases. But with a laryngo score of more than 9, almost 70% of the patients had difficult laryngoscope exposure. So 6 was defined as a criteria for good laryngeal exposure using these 11 factors, which included in. So it is very easy to understand all these 11 factors. We can start assuming from the degree of neck extension and flexion. So if we take extension and flexion and we see it is more than 90 degree or less than 90 degree, then we can see thyromental distance more than 6.5, 6.5 to 6 or less than 6. Then mouth opening, which means intra-incisor gap, any presence or absence of trismus. What is the upper jaw dental status, whether the patient has edentulous, partial dentate, normal dentate, or is there any prominent superior tooth? Having prominent superior tooth gives us a score of dental jaw status, a score of 3. Similarly, if there's any mandibular prognathism, then there's any micrognathia, macroglossia, any history of previous surgery, and what is the modified Mallampatti score, whether it is 1, 2, 3, or 4, and what is the BMI of the patient. The higher BMI had more than 25 BMI had a score of 1, and less than 25 had score of 0. Using all these factors, we can give a total score of the patient, and we can predict whether the patient is going to have a good laryngeal exposure or a difficult laryngeal exposure. And after we have define the exposure for the patient, then we see whether the patient falls under a reasonable limit for transoral laser microsurgery. See, a lot of paper is on the extent of transoral laser microsurgery, but there should be some limitation on when to go for it, because some people have gone and do extended or advanced T3 lesions also for transoral laser microsurgery. But this paper by Peretti et al. Has very properly given a review and defined that T1 and T2 and properly selected early T3 glottic lesion with minimal pre-epiglottic or paraglottic extension and supraglottic cancers with a favorable exposure should be the patient should be taken for a laser microsurgery. Any tumor with extension into vertical plane or extension into subglottis should be avoided for laser surgery. So the ideal case for transoral laser microsurgery are basically T1, T2 glottic tumors with pure horizontal spread, or T1, T2 glottic tumors with pure horizontal spread without anterior commissure involvement. Tumors extending into the vertical plane or extending into subglottis, they carry a higher risk of microscopic spread and they have a relatively lower local control. So they should preferably be avoided. So indications for transoral laser surgery is there should be adequate laryngeal exposure. Patient should not have any cervical disease. Our aim of treatment should be single modality treatment. We should not aim that we will remove a part of the tumor and then we'll give radiotherapy. No, absolute no. If we know in our assessment that we'll be able to remove the total tumor and we'll be able to reduce the number of modalities of treatment, then only we go ahead with transoral laser microsurgery. Resection should be unblocked. There can be piecemeal resection also. The resection should be with free margins. There should not be any nodal metastasis, because if nodal metastasis is present, we are with the patient gets upstage to stage 3 and it is not early laryngeal cancer anymore. Patient will require dual modality treatment. And patient should have a good physiological reserve to aspirate, to tolerate aspiration as well. But there are some contraindications as well, such as inadequate laryngeal exposure, trismus, cervical spondylosis, bulky tongue or buck teeth. The tumor factors which act as a contraindication, relative contraindication, is involvement of the anterior commissure. See, anterior commissure disease is a disease which has got relatively poorer prognosis because of multiple reasons, because of early microscopic spread, the pre-epiglottic space, involvement of the paraglottic space. Hence, anterior commissure has shown almost 15 to 16% poorer outcome as compared to tumors of which do not involve anterior commissure. So it is a relative contraindication. It depends on the overall exposure that we get for anterior commissure. Then involvement of the vocal process, any extension into the subglottis, arytenoid fixation, or massive infiltration of the pre-epiglottic space, or minor thyroid cartilage erosion involving T3. Before we go for TLM, obviously understanding the microvascular endolaryngeal anatomy is also very important. So we can see this is the superior laryngeal artery which pierces the thyroid ligament. After piercing, it basically gives the first branch, which comes as the epiglottic artery. This epiglottic artery was seen to be present in almost 100% of the patient. Then this common trunk moves forward and it gets divided into a posterior inferior artery and an anterior inferior artery, which will go and supply the area of the vocal cords and the paraglottic space. This posterior inferior artery again splits into two parts: the posterior inferior artery and the anterior posterior inferior artery. The posterior inferior artery is the main artery which bleeds when we are dissecting in the region of vocal cord, vocal process, or in the region medial to the vocal process. So this is the artery which bleeds when we are operating in the region medial to the vocal process. And there are multiple transverse arterial network between all these vessels. And there's one paracommissural artery. This paracommissural artery, it basically originates, it's a branch of the cricothyroid artery, which originates from the inferior laryngeal artery. It comes from behind. It provides it provides the vascularity in the area just inferior to the anterior commissure. So this and the anterior inferior artery, these are the main arteries which bleed when we are operating in the region of the anterior commissure. Mostly the paracommissural artery. The anterior inferior artery, it bleeds mostly when we are operating in the medial part of the paraglottic space, anteriorly near the anterior commissure. This is just a small video showing a lesion of the left vocal cord and the anterior commissure. So initially we are doing the hydrodissection. After doing hydrodissection, an anterior cut is defined on the right side of the true vocal cord. After the anterior cut, we can see the anterior cut being defined on the right side of the true vocal cord. After the anterior cut was defined, we went ahead and did try to, for a proper exposure of the true vocal cord, we went ahead with the excision of the false vocal cord. So this is the false vocal cord being excised over here. You can see false vocal cord being held and excised for proper exposure into the paraglottic space, because there was little bit induration in the free edge of the glottis over here. Now we are taking cut on the lateral part of the true vocal cord. This cut is extending. So preferably the first cut is taken anteriorly, and then because it releases the cord from anterior portion, and it is easier to take the cut in the posterior portion. So now we are extending our cut over here. We are defining our cuts, holding the true vocal cord. There is some charring also over there. So this is the paraglottic space in which we are doing the dissection. This is the lesion in the anterior commissure being excised. And this is the complete removal of the tumor, and this is the post-operative view. So this is the advantage of using the laser over here, that in the post-operative period, the bleeding can be controlled. Otherwise, if we had used a cold steel over here, there would have been a lot of steric hindrance, a lot of obstructed view because of the hand coming over there. So a very important thing while managing the patient with TLM is assessment of surgical margin. What is adequate margin? So there is varying opinion, varying literature about adequate margin. So there we have adequate margins has been described from 1 mm to 2 mm, but largely it is taken at 1 mm in most of the literature. For TIS or very small T1 lesions, 0.1 mm can also form a good or adequate margin. And there are issues with margin assessment in case of TLM, because the overall the specimen size is very small, and so there's shrinkage of the specimen size. So many a times the pathologists are also very reluctant to do a frozen section analysis and transfer laser microscopic surgery specimens because of the small size of it, and they'll say that we will not be able to give you a final histopathology report. So that is where the problem lies. We have to have a final histopathological report, because that is a proper and it is properly analyzed. Then because of the carbonization, the histological preparation and interpretation can be difficult, and definitely there's difficulty in freezing the sections. So now, as we discussed previously, that on-block resection is the preferred technique for removing the tumor, but for large tumors, piecemeal resections can be done, and actually it should be done, because when we are taking a piecemeal cut and we are cutting, then in that scenario we can cut the tumor in a transverse direction rather than coming from anterior to posterior. We can cut the tumor from medial to lateral. This will give an idea of the depth of the infiltration during the section, and from that depth we can assess our lateral margin or lateral point of resection. So based on the status of the resection margins, whether it is free, involved, or doubtful, European Laryngeal Society has they have given their recommendations for the follow-up of the patient for patients treated with laryngeal cancer using laser microscopic surgery. But the thing is that second look microsurgery is not well defined, and it is not very a well-established protocol is not present, but they do recommend a second look as a mandatory procedure in case of positive margins at final histopathological assessment. Because this controversy was there because in literature, many surgeons they have reported that if they are satisfied with the margin, and even if the frozen section shows positive margin or final histopathology shows positive margin, they prefer to keep the patient on follow-up. But ELS is strictly against it. They say that second look TLM is mandatory. They have yet not properly defined second look, the timing of second look TLM. They have not defined the timing of second look TLM. It varies from 3 to 4 weeks post up to 3 months. ELS general recommendation is from 1 month to up to the general recommendation in literature is from 1 month to 8 months. ELS has not commented much on that. Then comes the question of role of transoral laser surgery in difficult scenarios. Difficult scenarios means recurrent lesions, or as we have discussed, the anterior commissure lesions. So it has shown that it has been shown that the transoral laser surgery is a very good treatment modality even for recurrent tumors, and it was shown very well by this systematic review and meta-analysis by Ramakrishnan et al. From the Vinith Palleri UK group. They analyzed almost 11 articles with 276 patients. They showed that in radio recurrent laryngeal tumors, after first transoral laser microscopic surgery, the local control at 24 months was almost 56%. And after second TLM, though for those patients who required second TLM, the local control rate was almost 63%, which is as good as total laryngectomy. And the mean laryngeal preservation rate, it ranged up to 73%. So this was a very important data which came out from this study, and it showed that TLM can be offered as a modality of treatment even in radio recurrent laryngeal lesions. But the problem in radio recurrent lesion is the assessment of margin and intraoperative assessment of disease. Because of a lot of scarring because of radiation, there's difficulty in identifying the extent of infiltration, and there are increased complication rates as well. Now comes the question of anterior commissure involvement. So the anterior commissure has the TLM has shown a good response in anterior commissure lesions as well. But this is still a contentious issue because many studies have shown relatively poorer outcome. Many studies have shown good outcome and good laryngeal preservation rate. This is more so because anterior commissure involvement per se is a poor prognostic factor. There's a difference in local control rate at 5 years between T1 glottic tumors with and without anterior commissure involvement, and this difference ranges up to 12 to 13%. So this involvement of anterior commissure upfront puts a tumor into a poor prognostic criteria. Laser surgery is Definitely not without its own set of complications. There are beam-related complications, non-beam-related complications. Laser safety is of utmost importance. We have to make sure there is no eye injury, there are no airway fires or any dental reaction or injury. Then there can be patient complications intraoperatively. The patient might require tracheostomy if the patient lands up with some kind of laryngospasm or laryngeal edema. Patient can have a dental injury. There can be hemorrhage over there, and an unexpected hemorrhage, and this hemorrhage can require use of unipolar cautery, which defeats our whole purpose of using transoral laser surgery to get a clean cut margin. There can be post-operative complications such as dysphagia, aspiration. The patient has got poor lung reserves. The patient can have repeated infection. So we have to assess preoperatively with patient's overall functional status of the lung and whether the patient is fit for surgery or not. In late complications, there can be webbing of the anterior commissure. It's a very common late complication. Patient can have hoarseness of voice. There can be breathiness because of inadequate glottal closure. There can be pain. But definitely it has got a lot of risks and benefits. It provides good voice quality. It has lesser complication rates. There's the early rehabilitation of swallowing. There's no tracheostomy usually, no need of NG tube dependency, lower cost. The advantage of second look surgery, repeat surgery is present. The option of salvage using surgery or to use either laser surgery, microscopic surgeries, or partial laryngectomies, total laryngectomies, radiotherapy, all options are open when treating a patient. Appropriately selected cases using transoral laser microsurgery. The prime limitation of TLM is definitely learning curve. Anterior commissure, as we discussed, is a contentious issue. Visualization, if not adequate, we must not attempt resecting an anterior commissure lesion. And the other thing is web formation. Web formation in anterior commissure lesion is also an important consideration. So to conclude, it definitely the functional and quality of life outcomes of RT and TLM are important to guide the overall management. It is still an open debatable issue that which modality is treatment, which modality of treatment is better. We have good amount of evidence to say that transoral laser microscopic surgery has got a higher laryngeal preservation rate in appropriately selected cases. Anterior commissure involvement is a contentious issue. We should select the cases properly. We should say whether there is any preoperative space involvement or not. Definitely, neither modality is clearly superior. But the problem is that we do not have any level 1 robust randomized controlled trial between RT versus TLM or RT versus TLM versus open partial laryngectomy to adequately point in any direction as the preferred modality of treatment. Hence, currently in properly and appropriately selected cases, TLM, because of its higher laryngeal preservation rate and reduced treatment duration and overall reduced cost, becomes a preferred modality of treatment after proper consultation and consideration of the patient. Thank you.
Thank you, Dr. Ravi. I think it was a great presentation. Not only you included the technical aspects of laser machine, the functionality, you included all the clinical aspects as well as a very comprehensive review of literature. I think excellent presentation, and we are really thankful to you. There is one question, Dr. Ravi, can you take that?
Yes, ma'am, sure.
Do you do tracheostomy for all TLM pre-operatively?
No, we do. That is the whole idea of doing TLM. TLM is intended to reduce the complication and dependence on tracheostomy and NG tubes. So definitely tracheostomy, if tracheostomy is indicated, then better send the patient for radiotherapy. Why do TLM? We do not do tracheostomy for any of the patients pre-operatively. Thank you, Harikishore.
Thank you, Ravi. So any other question can ask directly also to Dr. Ravi. So I think if there is no further discussion, I thank you again, Dr. Ravi, for today's presentation and would request you to take lectures in future as well for us for our Saturday academic classes.
Thank you, ma'am. Thank you. It has been a great opportunity, ma'am. It is a matter of extreme pride and honor to be presenting on the same dais where I used to study once. Thank you so much for this opportunity.
Thank you, Dr. Ravi. Thank you so
Thank
much.
you, ma'am. Thank you, ma'am.